topic of discussion that we are going to deal about is we are going to talk about neoplasm of kidney, right? We are going to talk about renal tumors. Now what we'll do is initially we'll go through all these points, right, all these contents, and at last what we'll do is we will be describing the points from our first aid. Okay, now without delay, let's move into our topic. Now whenever we discuss about what neoplasm, the thing that comes in our mind is we talk about what we talked about, benign and malignant one, right? So there are two conditions here also. In case of kidney also we have two tumors, they are benign and malignant. And talking about malignant one, the thing that we'll be discussing is we'll be discussing about a renal cell carcinoma, right? And about Williams tumor we'll be talking into another lecture. And in benign one we'll be talking about what, angiomyolipoma, right? Angiomyolipoma, right? Similarly, another thing that we'll be talking about is we'll be talking about what, we'll be talking about our this oncocytoma, right? Similarly, other thing that we'll be discussing about is again there is another thing that we'll be discussing, and that is our what, renal papillary adenoma, right? Okay. Oncocytoma, right? Oncocytoma, and another is our renal papillary what, adenoma. So these are the thing that we'll be discussing. Okay, now without delay, let's jump into our topic, right? Okay, now talking about benign one, right? In benign also, the thing that we'll be discussing initially is we'll be talking about what, okay, the thing that we'll be talking about is we'll be talking about angiomyolipoma, right? Angiomyolipoma. Angiomyolipoma, from name it is clear. Okay, we have already mentioned that this is what, this is our what, this is our benign condition, and angio, right? Angio, myo and lipoma. That means here in this tumor there is what, there is involvement of our blood vessel. From angio, from myo we have got what, muscle tissues, right? Muscle tissue. And from lipoma we have what, lipid, right? There is involvement of lipid. So blood vessel, muscles and lipid, there is involvement of these three structures. Now what is going on is that epithelial cells, right, are having differentiated into these three structures in the case of this tumor. Okay, now another important thing that we need to know here is this angiomyolipoma, it is associated with tumor suppression gene, that is our TSC1, or it can be TSC type 2 gene, right? Now what is the function of this gene, this TSC type 1 or type 2? It is, what is its purpose? Its purpose is for differentiation, proper differentiation of cell. Now when there will be mutation in this gene, right, if there will be mutation in this gene, what will happen is that there will be improper differentiation of cell, right? Now if there will be improper differentiation of cell, then there will be many effect in different region of our body, such as there will be what, there will be effect in our skin, right? What will happen, there will be patchy appearance or hyperpigmentation in the case of our skin. Similarly, in the case of our kidney, what will happen, there will be what, angiomyolipoma, right? Bilateral angiomyolipoma that we are talking right now, right? Okay. Similarly, right, about kidney we're talking right now. Similarly, in the case of our heart, what will happen, there will be cardiac tumor, that is what, rhabdomyoma, right? Similarly, in the case of our CNS, there will be what, there will be seizure, epilepsy. So that is what, that is all about our this gene, TSC type 1 and type 2 gene, right? Okay, now okay, because of mutation in this TSC type 1 and type 2 gene, there are what, different manifestation in different region of our body. Okay, we are talking about what, we are talking about angiomyolipoma, right? We already discussed that what, that there are involvement of what, blood vessels, muscles and also what, our lipids. So vessels, muscles and fat, right, associated with tuberous sclerosis. Okay, yes, tuberous sclerosis. Okay, now let's see our diagram. Right here you can see what is this, this is our what, blood vessel. As you can see right here, right, there is what, there is involvement of blood vessel, that is angio, and here you can see what, there is lipoma, right? There is involvement of fat tissues right here. Similarly here myo, right, involvement of muscles. Okay, now here the thing that we need to know here is, right, as we have mentioned that there is association of tuberous sclerosis, right? Now what are the things associated with tuberous sclerosis is there will be what, there will be epilepsy, right? There will be epilepsy will be also related to it. There will be what, there will be also what, there will be, okay, as this point, right, there will be what, there will be epilepsy, seizures, right, rhabdosarcoma, similarly what, and similarly our angiomyolipoma, right, similarly there is our involvement in our skin, that is hyper pigmentation. Okay, this was about what, this was about angiomyolipoma, right. Now moving toward another benign condition, that is oncocytoma. Now the thing that we need to know about oncocytoma is that, right, now here, right, this, whenever we listen this onco, right, oncocytoma, oma, what does oma means tumor, and okay, that means oncocytoma, site, right, oncocyte. What does this oncocyte, whenever this word oncocyte comes, right, we need to think that it is the example of cell having large number of mitochondria. What? Large number of mitochondria. Now another thing that we need to know here is, these are what, these are large eosinophilic cell with prominent what, mitochondria, right, with prominent mitochondria. Okay, now another thing that we need to know here is, in our kidney, right, in our kidney there will be what, there will be tan brown color, there will be tan brown color in this case, right, and there will be also stellate scar, STELLATE, stellate scar, that is what, the morphological feature of kidney, right. Kidney in the case of our what, in the case of our oncocytoma, right, oncocytoma. Now there is one special there is one important point about this oncocytoma, right, it is it has similar, it is having similarity with subtype of our renal cell carcinoma, that is chromophore, right, chromophore, and that we will be discussing in detail about what, in our chromophore only. Okay, right here let's see, it arises from intercalated cell of collecting duct, right, one important point, where it arises from intercalated cell of collecting duct right, it is epithelial cell malignancy, and grossly what we'll see tan mahogany brown tumor. As you have said that, what was, how it was seen, it was, there was what, tan brown color in its appearance morphologically, right. Okay, histopathologically we were finding what, cells with abundant eosinophilic granules, right, eosinophilic granules, and here what was there was what, this was due to excess amount of mitochondria. Okay, now electron microscope, what we'll see in electron microscope, same thing, numerous mitochondria will be seen, as you can see right here, a maximum number of mitochondria are seen right here. Okay, now moving into the next discussion, and that is what, about malignant tumor of kidney. Talking about the malignant tumor of kidney, the main topic that we are covering right here is renal cell carcinoma, RCC, right. Another name for renal cell carcinoma is our hypernephroma, right, hypernephroma, and another name that is given on the one that discovered it is our Graves tumor, right. Okay, now it is mainly prevalent in elderly individual of 6th and 7th decade, right, and in the case of children there is our Wilms tumor, right, and it is mainly seen in the case of male individual, and here the upper pole is mainly involved, talking about geographical distribution, and it is also mainly found involved in cortex region, since the cortex is also the upper region of our kidney and upper pole, so we can just memorize it in such a way. Renal cell carcinoma, it will have two manifestations, one is sporadic and another is familial. Talking about the sporadic one, the main causes, right, the risk factor are our tobacco intake, and it is the most important one, right. Another is our asbestos exposure to petroleum products, carcinogens, similarly obesity that will result into hypertension, estrogen, right, estrogen, sickle cell trait, and our this ESRD, right, end stage renal disease. These are two immediate, or these are the new discoveries, right, and this end stage renal disease, what will happen is that at the condition of end stage renal disease, the support is done through dialysis, right. Now at the time of dialysis, what will happen in that during the long period of dialysis, there will be the association of cystic disease, right, there will be association of cystic disease, right? And this is what we say this is what we say that the ESRD is also what associated with our renal cell carcinoma, right? Cystic disease, and that may progress to what? That may progress to our carcinoma. Okay, now we're talking about what is sporadic and talking about familial variant. The thing that we need to know is there are several syndrome that we need to know right here. One is our Vhl syndrome. Now what is this Vhl syndrome? This is von Hippel-Lindau syndrome. Now okay, now to know about this syndrome we need to know about what Vhl gene. Now what is this Vhl gene? It is present on what? It is tumor suppression gene that is located on chromosome 3p, right? On 3p. What it does is it controls what? It controls the hypoxic inducible factor. It controls hypoxic inducible factor. Now as there will be mutation in this our Vhl gene, what will happen? This hypoxic inducible factor will be what? It will be hyperactivated, because of which there will be higher there will be increase in large number of vascular growth factor development, right? Vascular growth factor development, and these vascular growth factor development causes increase in cancer. So now what are the different clinical manifestations tried associated with this Vhl gene mutation? These are our renal carcinoma, pheochromocytoma, and our what? Cerebellar hemangioblastoma. So these are the tried associated with Vhl gene mutation. Now moving further, the thing that we need to know is another condition of our familial variant, that is hereditary Leomyomatosis, right? And this hereditary Leomyomatosis is also associated with it comes with renal cell carcinoma, and this renal cell carcinoma, it is associated with kidney and cancer, whereas this hereditary Leomyomatosis, that means what? It is involved with what? Smooth muscles tumor, particularly of uterus in female, obviously, right? Now what will happen is that in this case there will be FH gene mutation. What is this FH gene mutation? This is fumarate hydrolase, right? There will be fumarate hydrolase gene mutation. Okay, another syndrome that we need to correlate with this familial variant is our Birt-Hogg-Dubé syndrome. Now what is this Birt-Hogg-Dubé syndrome? Okay, whenever there will be Birt-Hogg-Dubé syndrome, we need to remember our acronym, that is short revision program. Okay, short revision program. What is this short revision program? From S we have got skin cancer, another from R we have got renal cancer, and then from P we have got pulmonary cyst. So this is what? This is our Birt-Hogg-Dubé syndrome. So this is about what? Okay, now another thing that we need to correlate right here is we need to talk about hereditary papillary cancer, right? Hereditary papillary cancer. Now right now this hereditary papillary carcinoma, it is less aggressive, or it is of low grade, right? Tumor, these are of two type. The first one is type 1, or it is also called less aggressive or low grade, right? Similarly type 2 is also there. Type 2 is also there. This type 2 is what? This is much aggressive, or it is of higher grade, right? These two, out of these two, this hereditary papillary cancer, it is of what? It is of type 1, low grade or less aggressive. Now here this hereditary papillary cancer, it is okay, now it is result of MET gene. Now what is this MET gene? This MET gene is our proto-oncogenes, right? Proto-oncogene, right? Now mutation in this MET gene, what will happen is that it will cause overactivity of MET gene, that will cause high rate of proliferation of cells, right? High rate of proliferation of cells, and that will cause cancer. Now okay, now here both of the kidney will be involved, so it is bilateral type. Okay, now okay, yes, we're talking about what? Hereditary papillary carcinoma, that it is involved with what? Our MET gene. Now talking about what we're talking about. Okay, now the thing is that we need to talk about clinical manifestation, right? Clinical manifestation that we see in the case of renal cell carcinoma is that, okay, we need to keep in our mind that here this clinical manifestation will be hematuria, right? Hematuria, and here it will be painless hematuria, right? And it is, but in the case of kidney stones there is painful hematuria, but in the case of renal cell carcinoma there is what? There is painless hematuria, and this painless hematuria is the commonest manifestation, right, that we see. And another clinical manifestation that we need to talk about is we need to talk about palpable what? Mass, right? There will be palpable kidney, right, because of what? Tumor. And there will be costovertebral pain, costovertebral pain. Now these three are called as classical triad, right? Classical triad. Similarly, other are also there, such as fever will be seen there, weight loss will be seen, similarly malaise is also seen, right? Okay. Now, okay, this was about what? This was about clinical, what? Clinical feature of our renal cell carcinoma. And talking about its diagnosis, how we are going to diagnose either its clinic renal cell carcinoma or not. We'll do CECT scan. Now what is the CECT scan? It is what? It is contrast enhanced CT scan. Now it is a radiological, here it is radiological there will be radiological finding that will detect exactly the disease, right? Here another thing that we can do is we can do renal biopsy, right? Renal biopsy can be done. Okay. Okay, now our this RCC is histologically adenocarcinoma, right? And this histologically it is a adenocarcinoma. Here now this our RCC is subdivided into various types, and talking about its types, now we are going to discuss about its type. The first one is our clear cell cancer. Now it is so important to know its the origin, right? The origin, this clear cell cancer, it is originated from proximal tubules, and it is the most common subtype of RCC, right? It is the most common subtype of our RCC, and it is because of VHL gene mutation. Yes, we have already mentioned about VHL gene mutation earlier, right? Okay, if you forgot, we talked about right here VHL gene mutation. Now this VHL gene mutation, right, now yes, it is what? It is unilateral, right? Unilateral and unifocal in nature. Now in this clear cell cancer, what we'll find is we'll find that, okay, the thing is, okay, in the case of this clear cell cancer, what we'll find is we'll find clear cytoplasm. This clear cytoplasm is because of tumor cell containing a lot of glycogen and lipid, right? There will be a lot of glycogen and lipid, and whenever we are going to process the tissue, the glycogen and lipid are likely to get washed off, and that is why there will be a clear appearance, right? Clear appearance with granule is seen. Okay, now here what are the shape of our cells? The shape of our cells are what? Round to polygonal shape, right? Clear cytoplasm is seen. Now it is the most common cause of, it is the most common type of RCCs, right? And it is originated from what? PCT, right? It is originated from PCT, and there is VHL gene mutation involvement, right? And it is unilateral and unifocal in nature. Okay, now talking into another type, and another type is our what? Our papillary cancer, right? Papillary carcinoma. Similarly, talking about its location, it is distal tubular, arise from distal tubular cell. Now here what will happen is that there will be increase in number of cells. That is why we are writing papillary. There will be increase in number of cells, right? And there will be the appearance of there will be papillary like structure, right? Papillary like structure will be there. Now it is multifocal and bilateral, opposite of our clear cell cancer. It is what? It is multifocal and bilateral, but here clear cell was unifocal and our what? Unilateral. Okay, now it is because of what? It is also because of sporadic and familial variant. Sporadic and familial variant, they are associated with trisomy 7, whereas our this trisomy 7, 16 and 17, it is our 16 and 17, it is only related to sporadic, right? Sporadic variant. Okay. Now this our papillary carcinoma is also seen in associated with dialysis induced cystic disease. It is seen in ESRD. What is this ESRD? It is end stage renal disease, right? Now at this end stage renal disease, there will perform dialysis, and because of excessive long duration dialysis, there will be what? There will be acquiring of cyst, and that may lead to what? That may lead to cancer. Okay, now here you can see, what you can see right here in this diagram is, okay, here I would like to make clear the multifocal cancer is means like this, right? Okay, multifocal. Okay, not multifocal means what? Multifocal means different glomeruli are involved, right? Many glomeruli are involved. So here you can see, what you can see is there will be basophilic calcium deposition, and if you will see cross section of this calcium deposition, you will find what? semoma bodies, right? Semoma body, and the semoma body is the characteristic feature of papillary cancer. You can memorize it as like this: semoma body. It is a characteristic feature of papillary cancer. Okay. Now there are other several example, other several condition in which there are semoma bodies, such as we can memorize it as most PG, right? Most PG. From M we have got meningioma, we have got mesothelioma. From O we have got what? Papillary cancer of ovary, right? From S we have got papillary cancer of salivary gland. We have got from T papillary cancer of thyroid. Similarly from P we have got what? Lactinoma, and from G we have got glucagonoma, right? So this was what? These were the condition in which there is the presence of semoma bodies. Okay, now moving further, what we have is we'll find chromophobe carcinoma. Now what is this chromophobe carcinoma? This chromophobe carcinoma, it is plant like appearing carcinoma. Now there, at this condition, there will be extreme hypoploidy. Now there will be extreme hypoploidy, that means there will be loss of many chromosomes, such as the chromosome number what? 1, 2, 6, 10, 13, 17 and 21, and it is associated with BHD syndrome. Now what is this BHD syndrome? It is Bitt-Hogg-Duyf syndrome. As we have talked about this Bitt-Hogg-Duyf syndrome, that is our what? SRP, that is our skin, right? Renal and pulmonary involvement, as we have discussed earlier right here: skin cancer, renal cancer and pulmonary cyst, right? Okay, now moving further, and this chromophobe carcinoma, it is what? It is having the best prognosis, and its origin is from collecting duct, okay, collecting duct, right? Okay, now here one thing that we need to discuss here is we need to discuss about what? We need to discuss about the appearance, right? Plant like appearance, how it is. So here what you will see is this outermost one, it is prominent cell membrane. It is the prominent cell membrane, right? Inner to it is our pale eosinophilic cytoplasm. Here it is pale eosinophilic cytoplasm, right? And here then inner to that we will see perinuclear halo, right? Perinuclear halo, and all these structure that shows what? Plant cell appearance, right? Okay, this was about our chromophobe carcinoma. Now talking about Bellini duct cancer, right? Bellini duct cancer, right? This Bellini duct cancer, right? It is having bad prognosis, BD, right? It is having worse prognosis, and what we will see is it arises from what? Arises from collecting duct, medullary region, right? Okay, this is what we need to know right here. And another is our what? Another is our medullary carcinoma. It is associated with our sickle cell trait, and it arises from collecting duct as our Bellini duct and our what? Chromophobe carcinoma. So this was about what? Medullary carcinoma. Similarly, XP11 translocation cancer, right? Now it is what? It is on short arm of X chromosome 11 number, right? X chromosome 11 number. Here there is the involvement of TPE gene that is found in the short arm of chromosome X11, and there will be what? There will be involvement of young patient, right? But in the case of maximum in the case of RCC we find what? Elderly patient. Now what? The most important thing that we need to talk about is we need to talk about metastasis. Now talking about metastasis right here in this carcinoma, it is so important to mention that there is no what? There is no lymphatic involvement. There is only angio-invasive, right? These are only angio-invasive. And another example of angio-invasive cancer is our hepatocellular carcinoma also. So what? So here talking about metastasis, we have got what? Lungs at the first, we got bones, we got liver, we got what? We got adrenal gland. So this was about what? This was about our what? Our metastasis. Now talking about, now going through the content of our first aid. Okay, renal cell carcinoma. Okay, now there will be polygonal clear cells. Okay, it is especially in the case of what? It is especially in the case of our what? Our clear cell carcinoma. If you remember clear cell carcinoma, there were what? Polygonal shaped cells, right? Filled with accumulated lipid and carbohydrate. Yes, they are washed up during the process, often yellow due to lipid content. Yes, we know that. Originated from PCT. Yes, it is talking about what? It is talking about our this one. Let me make you clear. It is talking about our clear cell carcinoma, right? There was what? It is originating from PCT. There was what? There was our polygonal shaped cells. Okay, now here moving further, what we have is, yes, it invade renal vein, may develop seal. What is this varicocele? It is dilation of veins, right? IVC, hematogenous spread, as we have said this, as we have said, right? There will be no lymphatic, only blood vessels. Okay, metastasis to lung and bone. Yes, we have mentioned the order. Manifest with hematuria, palpable masses. Yes, secondary polycythemia, flank pain, fever, weight loss, and treatment is done by what? Surgery, ablation for localized disease, and immunotherapy can be done, right? Or targeted therapy for metastasis disease, rarely curative resistance to chemotherapy and radiation therapy. Okay, now here clinical tried flank pain, palpable mass, and hematuria. Yes, we have mentioned about this tried right here in the case of our what? In the case where we are discussing about our, what is that thing? Yes, hematuria, painless, right, palpable mass, and our what? Okay, yes, palpable mass, flank pain. Okay, most this flank pain, right? Costovertebral we mentioned there as costovertebral, and most common primary renal malignancy, right? Most common cause common in male 50 to 70 years, elderly, increase associated with tobacco smoking, and obesity associated with neoplastic syndrome. Yes, and clear cells. Yes, it is all about clear cell. The most common subtype, yes, associated with gene deletion on chromosome 3, that is our what? VHL, right? We know that is our VHL. Okay, that is von Hippel-Lindau syndrome, right? Okay, now moving toward our renal oncocytoma. What is this? Renal, it is also benign condition, right? It is epithelial cell tumor arising from collecting duct. Yes, we know that thing. Okay, there will be circumcised mass, central scar, large eosinophilic cells with abundant mitochondria. Yes, perinuclear clearing. Okay, now yes, we are comparing this with our Chromophobe renal cell carcinoma, that is the malignant one, present with painless hematuria, flank pain, abdominal mass, often resistance to exclude malignancy, example renal cell carcinoma. So this was about what? This was about benign conditions mentioned in first aid. So this much for our this neoplasm of kidney. Okay, now in next chapter we'll be covering the remaining malignant tumor of kidney. So thank you and have a great time.